right, the cross-check. Now, as I'm saying that so the cross-check test is a screening test for the popliteal artery. So see the picture. The normal leg, the normal limb is this. What you have done is that the abnormal limb with the artery is being compressed at the popliteal fossa. Now, if it is a normal circulation, it will still allow the blood flow to happen because it has maintained the elasticity and the lumen is good enough to allow the blood to go. That means in a normal leg, you will get the pulsation or the the pulsation or the pulsatile movement of the foot. Whereas if it is a chronic limb disease or a chronic limb ischemia, what is going to happen is that the lumen is going to get narrowed. If the lumen is going to get narrowed, then the major problem that starts is that there is no pulsation. But I feel that the test is very difficult to commence and to make the patient understand is a very tough one. These things have been gradually replaced by much better ways like in Doppler, but still people will do that. For the best method for the popliteal artery palpation is the patient. Now this is a picture that I took from one of the textbooks of surgery. Patient lies prone, not supine. See the picture. Now it is done at a 90 degree, and in this 90 degree, please remember that it is kept at a 90 degree, and now the hands of the observer at the left hand, which palpates at the intercondylar area of the femur. The first technique is tibia. Second technique, no palpation. Third technique, the best one, is to palpate it against the femur. Common femoral is felt exactly like the way you were taught in the hernia topic. You find the mid-inguinal point and then go about 2 inches, that is 4 centimeter to 5 centimeter, in the line below the mid-inguinal point against the neck of the femur, which is the common femoral. The radial artery in the upper limb is very simple because all of you have done this many times. Remember, the hand is held semi-prone. For that, the bone is the styloid process of the radius. Now, the ulnar artery, I have made this picture wrong so that you can command this longest. Can anyone of you tell me what is wrong in this picture? Hello? We can hear you. Hello? Can anyone of you tell me what is wrong in this picture? Which one?
No, sir, you're doing it on the radial side.
Exactly. Very good. So I'm palpating it on the wrong side, the radial side. On which side do you find the, or how do you find the pisiform bone? How do you find the pisiform bone? This picture, I took this picture with many flaws so that you can, or you cannot sleep now. No. So the pisiform is palpated by finding the palmaris longus tendon and going medial or ulnar to this. That means I should have made a picture in this region. This is the area that should have contained the pisiform. Okay, and the artery, mind you, is now, if you can feel your own pisiform now, and you will feel that the artery is radial. That means towards the thumb side on the pisiform. So if you can see that, this is the location of finding the artery. So this is the way of finding the ulnar artery. Remember that the hand is hyperextended. Now, brachial, as you know, is a 90 degree.
Sir, will we again use 3 fingers to palpate or single finger as shown in the picture?
You will not get a space for replacing 3 fingers. The radial styloid allows you to place 3 fingers. Try to find it over the distal end of the ulna. In a normal human being with a fat around, it will not allow you to place 3 fingers. It is 1 finger. Now, brachial is with your thumb, medial to the tendon of the biceps. The axillary artery, remember, is again like palpating the lateral group of the axillary nodes, and you come on that side. This is against the shaft of the humerus. So, the last ones are carotids, which you know are felt against the upper border of the thyroid cartilage, anterior border of the sternomastoid. The bone in concern is what bone? Which is the bone?
The transverse process of C6.
So it is the C6 vertebra. The Cheshire tubercle of the C6 vertebra is a much specific answer. So very good. So please remember, examiners would like to ask you upper border of the thyroid cartilage, anterior border of the sternomastoid. So this talks about this part, right? Now, so superficial temporal is not very commonly asked in exams. Okay, but in cases like this condition called as a cirrhoid aneurysm, this can be one among the questions. Now, finally, talking about how to say your diagnosis and what is a Buerger's disease. Now, whenever you talk about a Buerger's disease and whenever you talk about how to say your diagnosis, then your diagnosis, some examiners again are very meticulous in asking what is your diagnosis. The diagnosis is a 65-year-old gentleman, GM is a gentleman, suffering from a chronic limb ischemia, probably due to atherosclerosis. Now, I do not like the word probably, it is a clinical diagnosis. Probably is not a good word. Complicated by
Hello, sir. There's no audio, sir.
right. Okay, sir. Now, so this completes. So this is all about what is the Buerger's disease. There are out of multiple criteria like Shearner, Olin, Mills criteria, etc. I will always ask you to remember only this part. Know about this. These are all more difficult. Examiners will ask you what are the Buerger's that you know. So Buerger's disease is a form of vasculitis due to nicotine and tobacco. What is Buerger's test and Buerger's angle? Buerger's test and angle means that you tell the patient to raise the legs or you help the patient in raising the leg. Normally, even if the leg is raised up till 90 degrees, the color remains the same and the pulse remains the same. The patient has no pain. Whereas in a case of a limb arterial occlusion, at an angle, say for example, this angle called as a Buerger's angle, the patient has a pain on this part or there is a presence of a pallor that appears. Now, when Buerger made that, there was nothing called as an arterial Doppler. So, Buerger proposed that if this angle is less than 40 degrees, some people say 30 degree or less, that is said to be something called as a critical limb ischemia. But nowadays we have become more clever and we have said that no, this is not about this angle stories anymore. Critical limb ischemia is defined by something called as not as this one, by a Fontaine's criteria, which talks about presence of a gangrene, rest pain, ulcer, MBPI less than 0.5 and a toe and ankle pressure less than 50 and 30. So that is a Fontaine's criteria. Now, what was interesting in this Buerger's angle concept was that the angle correlated with the ankle perfusion pressure. So this was not a very strong corollary, but this was a working formula. Ankle pressure. So that means whatever is the angle is equal to the angle pressure or the pressure of the blood pressure at the ankle. So if it was 30, meant that it was less than 30. So the Fontaine's criteria talked about an ulcer, rest pain, or an ABPI less than 0.5, or an ankle pressure less than 50, or a toe pressure less than 30. So this is all about Burger's test. Burger's exercise is about telling the patient to keep the legs up, then sit with the legs down, and then make sequential movements into that. So this is called as a Burger's position and exercise like this. Lastly, we'll skip about amputations. If there are, you will like to see about what are the stumps and what is the state. Upper limb is very rare to be given. If you are given, please remember Allen's test is something that you should do before any arterial blood gas. I hope you know how to do the test. Addison and Bruce, particularly Addison, is a common thing, oxygen and thoracic outlet obstruction. Finally, before I end and take your questions, this is something like an handheld Doppler for a varicose vein. An ABPI needs to be measured, particularly in many hospitals. A postgraduate is known to measure an ABPI. See where the cuff is tied. Brachial artery, you know, I know that. Radial, now the leg arteries are the same cuff, maximum can be tied at the leg, but you need a different cuff. And then you see this in the arteria dorsalis pedis or the posterior tibial artery, not the popliteal artery. So you divide the brachial, so ABPI mean ankle brachial pressure index. You divide the ankle, the systolic blood pressure, the best reading, whereas the brachial, the systolic blood pressure, the best reading possible. So these are the two things, and then divide. Normally an ABPI is in a range around 1 to 1.4. Is something there is no disease. If it decreases from 1 to 0.8, the narrowing is not significant. If it is 0.8 to 0.5, there is a moderate disease. 0.5, critical limb ischemia, which is not a very nice thing because the patient is going to lose his leg. And 0.3, okay, it is not critical. This patient is going in for a gangrene and an amputation. Okay, so this is all about more than 1.4 Celestin calcified arteries. So guys, this talks about your methods in an arterial disease. Examiner, if asking what is your plan in treatment, so the only basic plan in treatment is that, now this is a point that many students do not know what to say. If the patient has an ulcer or a gangrene, then say to the examiner, sir, my priority number 1 is to treat the ulcer or the gangrene. Now, out of the gangrene, remember that if that gangrene is a wet gangrene, definitely that wet gangrene at least will require a form of a debridement. Okay, and in future will require an amputation. Whereas, remember, if it is a dry gangrene, if it is a dry gangrene, remember that if it is a dry gangrene where the tissues are mummified and you have a line of demarcation, there is no signs of sepsis, then remember you can plan in an elective amputation. But remember, this elective amputation is usually after the color Doppler to show you exactly. That means if you are planning in for an amputation of this, maybe you had planned for a 4-foot, but the Doppler told you that the blood has stopped at the level of this. So the better amputation would have been a below knee. So think about the Doppler and then plan an elective amputation. Whereas then the other part of the story is, I will like to confirm my diagnosis about the level of occlusion by doing something called as a color Dopplex. Now, someone of you had asked around, what is this investigation? This is something called as an ultrasound of the tissue. I hope you know what is an ultrasound. Now, an ultrasound of the tissue can be done in a mode in which the wave comes and the wave hits the surface. Just sorry, the wave hits the surface and returns. This is like a bat who is flying and gives it. This is called as an amplitude mode or an A mode. If you now have this wave in an x-axis, y-axis, this is called as a B mode. So if you hear that, this B mode, so what you can do is that in this one, if this is the artery, you can place your probe and the RBCs which are traveling across this will give you a sound. So this is called as a B mode Doppler. I hope you know what is the Doppler effect of sound. It is looking like a train approaching and leaving a station. And now what you can do is that, so you can combine them and it is called as a duplex mode. So a duplex mode is basically an x-axis and a y-axis with a Doppler thing. Now what is color means that the color is coded by your machine in which that if there is something that is approaching the probe, it will be given a color of red. If it is going away, it will be given a color of blue. If it is static at one point, say for example, blood is static at one point, it is given a color of yellow. So depending upon the velocity of the blood, the color of the circulation, and what is the stature, you can now have the two-dimensional anatomy. So it is basically will give you a two-dimensional anatomy of the vessel wall. It also gives you the direction of the flow, and it also gives you what is exactly the B mode. Now, in a B mode, you will occasionally get to hear words like something called triphasic, which is a normal one. The lumen is absolutely normal, or the occlusion, if it is very minor. If the occlusion goes more into the lumen, remember that one will be called as a biphasic. Whereas a monophasic means that the lumen occlusion is so severe, see that the amplitude A has decreased and the monophasic signal means that this narrowing is very critical. So if you are planning an amputation, always remember amputations are always considered with at least a biphasic signal. So the next time you answer, sir, say to the examiner that, sir, I will like to go for a color duplex B mode ultrasound to confirm the level of occlusion. Number two, I will also parallelly suggest a lifestyle management or lifestyle modification for the patient, which will include diet, which will include drug, which will include exercise like walking to make the collaterals much more. So after you have done confirmation and drugs like aspirin, etc., the last point is now I need to consider after this point the level of narrowing, the length of narrowing, okay, and what is the distal vascularity, particularly in relation with gangrene and necrosis. For this point, as I have said, gangrene will always require an amputation. But what you can do is that at this point, your Doppler has told you that level. Now see the creatinine function or the renal function. So see the creatinine function. If the creatinine function or if the urea creatinine is okay, you can go in for a CT angio with an injection of a dye. Otherwise, not okay, you go for an MR angio. But both of them are going to tell you that if this is the artery, the arterial lumen has narrowed significantly, and then as you can see, so it tells you what is exactly on an angiogram, the length of the narrowing, Number 2, what is the status of infrapopliteal vessels? Number 3, what is something called as a distal runoff? Examiners will love to hear this word. That means these words. And after this, the state of proximal vessels. So this is all about this one. Please remember that digital subtraction angiogram is a form of a therapeutic procedure when you are planning for a stenting. If the length now, these narrowings are classified depending upon transatlantic society classification, and after this you need to take a call whether you can at all go in for a revascularization versus an amputation. If you are planning a revascularization, whether you are going in for a stent versus a bypass. So these are all the things that we talk about in a vascular disease. So I think that I will end the vascular class at this point. Any queries or questions now, please? Hello? Hello? No queries. We can hear you, sir. We can hear you. Thank you. So this is how majority of times in your DNB and MS examination. In Berger's, there are lots of magical therapies like people do, includes lumbar sympathectomy, omentoplasty, and all these funny operations which have no role technically, believe me. Lumbar sympathectomy is only done to relieve the pain. But the cost that you are doing is that the claudication distance decreases. Number 2, the ulcer healing that occurs is a transient, the disease progression is fastened. Okay, so any more questions in the arterial or the venous disease?
Sir,
Yeah.
sir, in a case of dry gangrene, should we straight away proceed for an amputation, or can we just manage?
No, you can. As I've said, dry gangrene, no sepsis. See, the problem about an amputation is that you are not sure about the level of amputation. The dry gangrene is not going to produce any sepsis. Rather than do an operation twice with a stump not being healing, it is better to see the Doppler, to see which one has a biphasic signal, and then plan a proper amputation. Say, for example, let me show you a picture of a dry gangrene. And then you are going to tell me, sir, that this is the point that I think that yes, you are right, that this chap should have had an amputation. Just let me show you this part. This picture. You see this point is, can you see the line of demarcation very well? You can. Now, the problem is that, can you also see that there has been an auto amputation that has happened? But after the auto amputation has happened, the problem is that the stump is not going to heal. So that means if you are planning to do a proper amputation, don't you think the first thing that I will like to see is the vascularity? How can you see the vascularity? By doing a Doppler. Hence, for a dry gangrene, now in a wet gangrene, this is sepsis, as I told you, crepitus. Okay? So this completes your answer.
Thank you.
Right. I think that will, any more? Okay, no more questions guys on vascular, so that we can go to head neck now. Right? Complete? Hello?
Hello, sir.
Yes, sir. Right, go on.
Sir, why venous ulcers have sloping edges?
Because venous ulcers are only phase of healing. Hence, venous ulcers occur in a tissue because all ulcers which have a, if you understand how does a venous ulcer occur, or what is exactly the pathology of a venous ulcer, understand the pathology. If the examiner is asking you this one, say that, sir, the ulcer is a healing ulcer and hence it has a sloping edge. Then the next comment that you should say is that, sir, in a venous ulcer, the basic pathology is that the subcutaneous tissues have a lipodermatosclerosis, which produces a transient ischemia to the tissues. So if these are the arteries which are there, now out of these arteries, where did this marker pen go? Yeah. Now out of these arteries, as you can see, these are all the lipodermatosclerosis that is going to happen. That means there is a lot of fibrosis in the subcutaneous tissue. Now, out of this fibrosis, the majority of the problems, say for example, is occurring in this place. Okay, and as you can see in the picture that I have drawn, these arteries that are there, these arteries are gradually getting choked off, or arteries are getting blocked off. And ultimately, this part of the skin is without a good blood supply. Can you see that more we go to the periphery of the lesion, more the blood supply is remaining? So that means this part is ultimately and effectively is having what kind of an edge?
Sloping edge.
Sloping edge. That is the reason.
Okay, sir. Thank you.
Okay. Thank you.
Yes, sir. Yes.
So I think we have had a long discussion on vascular. Let us have a quick discussion on head neck. Now on head neck, guys, the case discussions on head neck, definitely head neck will not be done in an hour. It takes long time. So I'll try to have a quick summary about the cases. The number one case of the day, definitely in a head neck, is always about thyroid. Always. Thyroid is the number one case in concern. Definitely followed by oral cancer or oral cavity cancer is the second one, very commonly given in an exam. Number three is a carotid. Number fourth is a neck node. Or number fifth are other neck swellings like cystic hygromas, branchial cyst, and those ones. So usually these are the points that are given in a head neck. Definitely out of these, as you can imagine, thyroid is very important. The most important point maybe, followed by an oral cancer, okay, which is I feel very important. And then you have a carotid, which is also very important. Nodes are important. Examiners sometimes they give that in your exams. So let us have a quick recap about or discussion about what are these cases. Now, whenever you have a patient with a thyroid swelling, few basic fundamental questions rather than showing you pictures, which is going to take a lot of time. I will give you just an examiner's or a student's algorithm on how to I approach this swelling. Number one is that I know that all of you are pretty exhausted. So let me show you my approach, Ramanuj's approach to a thyroid swelling. Okay, oh my God, yes, so long in neck, looks like an extraterrestrial. Okay, now the first point is that let me have a swelling in the neck. Now, rather than think of it as a thyroid swelling which confuses the picture, what I will do for you guys is that I will make this as a neck swelling or a neck lump. Now, whenever we have a neck swelling or a neck lump, ask yourself a very fundamental question. Is it in the midline? Is it a lateral swelling? Now, what do you mean by this midline and what is this lateral story? The midline story means that anything that is between the two borders of the sternomastoid are again something that is called as a midline swelling. That obviously and automatically means that anything in this region is something that we call as a midline swelling, and anything that is by the side of the sternomastoid, that means behind or in between the two borders of sternomastoid or behind the sternomastoid, is thus considered to be a lateral swelling. So please make your fundamentals very clear. Believe me, if you are thinking that, oh my God, we knew this everything from undergraduate, yes, I know that, but people get stopped exactly at this level. So this is the first one that you have your algorithm for, that this is a neck swelling in midline and the lateral one. Now, if it is a midline swelling, then ask yourself next question. The first question is, does it move? Does it move with deglutition. If it moves with deglutition, I'm bad with spelling, so forget me for bad spellings. If it moves with deglutition, your answer is a yes, then maybe this is a thyroid swelling or we have a differential diagnosis. If it has no movement with deglutition, then remember it is not a thyroid swelling. And then see the relationship with the platysma. In the neck, remember the layers of our skin followed by the platysma, followed by the investing layer of the deep cervical fascia, followed by the subcutaneous fat. Now, the reason subcutaneous is thus, as you can imagine, the word subcutaneous is not a very proper word. So, we have the word subcutaneous is not at all a very proper word to have. So, subcutaneous fat is this. That means even if you have a lipoma in the neck, remember that in the midline of the neck, this is always the structure, and all structures are usually deep to the platysma. If it is not moving, then think over what can this be. Please always keep in mind that a lipoma is a soft swelling, can sometimes be formed if there is a fibrous component to this also. So in the midline, always remember about this swelling. Okay? Does not move with deglutition. Always think about this. Now, if it does move with deglutition, we have a differential diagnosis with the thyroid. And the next question that you get is, what are the other swellings that move with deglutition? Number one, always guys, is a thyroid swelling. Number two is a thyroglossal cyst. Number three is a prelaryngeal or a prelaryngeal or a paralaryngeal node. Remember that the Delphian node, which usually dents the isthmus of the thyroid or the thyroid, is the precricoid node in the level 6. So the Delphian node is the precricoid node in the level 6. The fourth one is usually an external laryngocele, which is seen in a very small cohort of patients. The number fifth one is usually a subhyoid bursa, which I have seen only once in my life, many times in exams to be mentioned, never to be found. So let me ask you again the question. What are the swellings that are in the midline and move with deglutition? Understand the picture. What are the swellings in the midline? Now, what is midline? Area between the two anterior border of sternomastoid. Now, what are the swellings that are there in the midline? So, the midline swellings, number one is a thyroid. Number two is a thyroglossal cyst. Now, number three are lymph nodes, etc. Now, the examiner is going to ask you, boss, guys, how to differentiate between a thyroid swelling and a thyroglossal. Is my sound audible? Hello? Is my sound audible?
Yes, sir.
Right. There was an audio problem. Now, so how to differentiate between a thyroid and a thyroglossal cyst? Now, everyone says protrusion of the tongue, but before that, number one, the thyroid. The thyroid, it is not from my answer. Okay, let me do an exit and let me join again. Or let me.
It is not from your side.
Am I audible now?
Yes, sir.
Okay. Let me have my screen now. Is the screen visible?
Yes, sir.
Hello? Right.
Yes, sir.
So if the screen is visible, now let us come to the thyroid again. So now when to call is, or why did you call this swelling to be a thyroid swelling? Now the important points to talk about in the thyroid swelling includes, number one is that, as I've said, both of them are moving with deglutition. So the point number one, where did that marker go? Yeah. So the point number one in the whole box is to make you understand that it moves with deglutition. Point number two, so both of them moves with deglutition. Thyroid swellings are always seen in a zone called as a thyroid region. Now please understand the picture that I'm trying to draw. This makes the thing much easier. The thyroid region is very characteristic of this thyroid swelling only, not of a thyroglossal cyst. Now, so what is the thyroid region? What are the boundaries of a thyroid region? So the superior boundary of a thyroid region is limited above by the hyoid. The inferior boundary is limited above by the level of the clavicle. The lateral boundary is the anterior border of the sternomastoid. Some people say no, it is the posterior border of sternomastoid. So let us not go into controversies. Let us talk that. So this is the boundaries of the sternomastoid, and anything in this swelling that moves with deglutition thus is better called as a thyroid swelling. Whereas on the other hand, if you see a thyroglossal cyst is usually in relation with the bone called as the hyoid bone. Majority of the thyroglossal cysts, always understand, are in relation with the hyoid bone. Now, it is not that they are always much close to the hyoid, but what is important is that this swelling are usually subhyoid in location. They are usually subhyoid in location. Now, they can be prelaryngeal, infralaryngeal also, but that is not common to locate. The last one is movement with protrusion of the tongue, which is very characteristic of a thyroglossal cyst because of the picture that you drew from your undergraduate days. The thyroglossal cyst looks like a pendulum. If this is the pendulum, remember that the pendulum is in relation with the hyoid bone. And this tract is called as a thyroglossal tract. So this tract in concern is called as a thyroglossal tract. Now, so when the tongue moves forward, definitely as you can see, the swelling will thus move upward. Okay, please don't say upward and downward, it moves upwards on protrusion of the tongue. Okay, so that is the main point to know about what is this thing. So this is the hyoid story. So this is the movement with deglutition, thyroid region, and the movement with protrusion of the tongue. So this is the reason why we called it as a thyroglossal cyst. A thyroglossal cyst, some people say that, I do not like that point very much, is known to have a sideways mobility. The longitudinal mobility is not a very appreciable thing, but the sideways mobility is always an appreciable point of concern. Okay, so this is what makes it as a thyroglossal cyst. Now, before we talk about the thyroid anymore, thyroglossal cyst is treated by an operation called as a cystrum's operation. The principles of this operation includes that you take out the cyst and then in toto with the tract. As the hyoid was in close relationship of this, the body of the hyoid, and finally you take out a few fibers or bits of the tongue musculature, particularly the hyoglossus muscle. So tongue musculature, the hyoglossus, the body of the hyoid, the tract and the cyst. This is to prevent the recurrence. So this is all about things that you should know about in this part. Now talking again, coming back to the thyroid. So the first question that comes for midline swellings are, is this the thyroid? Now guys, once you have known that this is nothing and nothing but the thyroid, then ask yourself the second question. If this is the thyroid, the first question is that, oh, by the way, I really forgot, why does the thyroid move with deglutition? Okay, so I really forgot to ask you that one. Anyone in the group, why does the thyroid move with deglutition?
Ligament of ligament of Paris.
Holy God, oh my God, I will say, oh my God. Really? Thank God I really remembered to ask you this question. Why does the thyroid move with deglutition?
It's enclosed in the pretracheal fascia.
2 and 3. Okay. Those of you who voted for ligament of Berry, guys, that comes number 3. What is the number one reason that thyroid moves with deglutition?
Enclosed in the pretracheal fascia.
Important answer, sir. Good answer. That is number 2. What is the number 1?
It's a constriction of the inferior cavity.
Very good. Sir, remember that this is the thyroid cartilage. Thyroid cartilage articulates with what cartilage? Cricoid, thyroid cartilage. Okay. And this is thereafter the trachea. What is the muscle that is exactly behind this one? What is the tube that is behind this one? Is the pharynx. Remember that? And what is this muscle that is attaching from the pharynx to the thyroid called as thyropharyngeus? And what is this one, guys? What is this muscle? Cricopharyngeus. Remember Jimker's diverticulum? Now, with each deglutition, what is moving upwards? The thyroid cartilage. So if the thyroid cartilage is moving upwards, now tell me, what is this structure that is present in front of the trachea? Is the thyroid. So the number one cause is attachment with the movement of the thyropharyngeus muscle. This is a very common question in exam. Why does the thyroid move upward? Is a thyropharyngeus muscle contraction. The pretracheal layer of the deep cervical fascia encloses everything in a single compartment. Hence, it is number 2. The ligament of Berry comes as a condensation at a last point. So this is the ligament of Berry. If these are the isthmus, the 2 lobes of the thyroid, this is the ligament of Berry. So please say that. So this completes your answer. Why does it move with deglutition? Now, how do I make a diagnosis and what are the things that I look in a thyroid swelling? Very important points. So number 1 is that whenever I have taken that, if this is the thyroid, I'm telling you exactly what I will do in an exam. As I've looked into a thyroid, I will look into whether the patient is toxic or whether the patient is non-toxic. Now, I'm not exactly going by inspection, palpation, percussion, auscultation. I'm not doing that. I'm doing what exactly I will do in an exam. I will look into that whether it is thyroid, and then I will look into whether there are problems of toxicity and non-toxic. Now, toxicity and non-toxic, we'll talk about toxic, but remember that the main thing that goes in favor of toxicities are eye signs, pulse rate, which is a tachycardia, okay? And remember the symptoms that the patient may have had experience. That includes a remarkable symptom of an unexpected weight loss. So symptoms of a weight loss, increase in pulse rate and eye signs. All of them are very important for deciding on toxicity. Now, if it is toxic and you have a patient with a thyroid swelling, where the patient is toxic and both the lobes are enlarged and the patient is toxic, then what is your tentative thought? If the surface is smooth, maybe with fine nodularity, that is not important, okay, and the symptoms had started, that means the onset of the symptom and the goiter more or less have been closely related by 6 months to 12 months. That condition is called as a diffuse toxic goiter, also called as a Graves' disease. That is called as a diffuse toxic goiter, also called as a Graves' disease. Okay. Whereas on the other side, if you have a patient with a bumpy nodules and the patient is toxic, the diagnosis becomes a toxic multinodular goiter, also called as a Plumer's disease. Okay. Whereas if you get a patient with only a solitary thyroid nodule, I'm coming to a solitary thyroid nodule, but that is a toxic, your diagnosis becomes a toxic solitary thyroid nodule or a toxic adenoma. The name is a misnomer, it is not a tumor. Okay, so this is this part, so it is called as a toxic adenoma. So please remember that this point, thyroiditis is a very difficult thing to diagnose clinically, however, so people will make confusions with this. So remember that thyroiditis is a very difficult thing to diagnose. We are not talking thyroiditis. Okay, so this is all about diffuse toxic goiter, toxic multinodular goiter, toxic adenoma, and this point. So this is all about this point. So toxicity and this. So this completes what are the toxic. Now, more management will come to management later. When it comes to non-toxic, the only thing that you need to do is that please palpate the thyroid. You can have three scenarios, guys. One, scenario number one is, I don't have space to write down here. So when it is non-toxic, what are the scenarios that I can have? Not two exactly. I will have four scenarios. And to make you understand that, I draw a very simplistic picture. Scenario number one or condition number one is patient has both the lobes of the gland enlarged and both the surface is smooth. So both lobes and the surface is smooth. The patient, remember, is euthyroid or hypothyroid or non-toxic. This is an example of something called as a colloid goiter. Okay, also called as a simple goiter, also called as a diffuse non-toxic goiter. So daily life tells it to be a diffuse. Colloid is a pathology term commonly used. Diffuse non-toxic goiter and this. So this completes the story. Now, on the other hand, if it is in such a state that the surface is nodular and you could either on inspection or on palpation. So I have drawn your hands now. So either you have inspected or you have palpated this one, and this then becomes something called as a multinodular goiter. So I hope you have understood what is a multinodular goiter. So now, remember, all patients are euthyroid, so they are non-toxic, they are euthyroid or hypothyroid. Now, the third one, remember, is a patient who doesn't have both the lobes enlarged but has one part of a lobe. So that means the rest of the gland is not palpable. The rest of the gland is not palpable, but there is one part of a lobe that is palpable. Or it could be that the whole lobe became palpable along with the isthmus. So this is the whole lobe that became palpable along with the isthmus. So this is the thyroid. Now, so this is called as a solitary thyroid nodule. So technically enough, if you ask me, sir, what do you exactly mean by the term a solitary thyroid nodule? Now, solitary thyroid nodule is always a clinical entity. Is my screen visible to everyone? Hello?
Yes, sir.
Right. So STN is a clinical entity. Please remember that. If you have commented on a pathology diagnosis that this is an STN, the pathologist is real stupid. But STN is a clinical diagnosis, nothing more. Because after a radiology and after a pathology, your diagnosis is going to change. What are the pathologies that can make an STN? The pathologies that can make an STN are out of the four. One is that the patient had a multinodular goiter. As you can see, I'm trying to draw multiple nodules in the gland, but all of these nodules are small in size, so small that they were not palpable, and out of them, suddenly one of the nodule became large in size, and out of that, this nodule which became large in size, that nodule was palpable. So basically, it has a background of a multinodular goiter. Some people call it as a nodular goiter. But out in this nodular goiter, some people call it as a colloid nodule. Now, various confusions and unnecessary confusions. But this nodule is called as a discrete nodule. So mind the terminology. So that means the patient came with a nodule. This was a part of a multinodular disease which will be detected on an ultrasound. But that nodule was much more prominent than the rest of the nodules, which is a discrete nodule. Mind you, the same terminology is used in a toxic multinodular goiter. Then, out of this, one nodule, which is biologically more active than the rest of the nodules based on the uptake functions, is called as a dominant nodule. So, but both of them are used interchangeably. Dominant is to do with the function and discrete has to do with the size. So an STN, the first condition with around 50% of the patients who are going to have this is this point. Point number two is 20% are going to have a papillary cancer of the thyroid. 20% patients are going to have an adenoma, or better called as a follicular, not adenoma, but a follicular neoplasia, which can again be either an adenoma or a carcinoma. Remember, that is all combined to be 20%, whereas the 10% of that is called as a cyst in the thyroid. So there are four conditions. What are the conditions that can lead to a solitary thyroid nodule? A multinodular goiter with a large nodule formation, a papillary cancer thyroid, follicular neoplasia, and 10% as a cyst. So this is all about the last condition. Now, so the last one out among the four can be a suspected cancer. Now, when will you call a thyroid cancer? Very common question and a very common confusions in exam. Thyroid cancer, please remember, whenever you are talking of this in a clinical perspective, whenever I talk in a, am I audible, guys? Hello?
Yes, sir.
Right. Whenever I'm talking around in a clinical perspective, not FNA, not FNA, not FNA, I repeat this thrice, not FNA. I'm talking clinically. Clinically, you have only a goiter. Mind you, clinically, you have only a goiter. Clinically, this is a goiter. No nodes. FNA may give papillary cancer is not at all my worry. The only question is that if this is clinically a goiter, then if there are nodes that are palpable, clinically, as I've said, clinically, or detected on an ultrasound. Ultrasound can be your extension. Okay, I agree to that. But clinically, I see the word clinically. Then and then under that condition, will I say, sir, this is a patient with a cancer or a carcinoma of the thyroid with a nodal metastasis. Until and unless I have a carcinoma, even if the thyroid feels firm or hard, it is very difficult to say it is a cancer clinically. Lab pathology is something that I'm not interested on. In an exam, I need a clinical diagnosis. So this is what is my answer. There can be other rare events like having a diarrhea in a medullary thyroid cancer, lateral aberrant thyroid in papillary. Those are extremely rare. Follicular will occur in a long-standing multinodular, and those things can go on. But until and unless, guys, you get a node, think of it today evening. How many of you can by clinical examination say this is a cancer? You may say this is a non-toxic goiter, and I want to discuss the differential diagnosis. Like out of this, if the surface is smooth, even if the FNAC is a papillary, I give a real damn. Because clinically, how could you know that was a papillary? Understand the logic. So this is what is my approach to a goiter. Now, any multinodular goiter, now the issue about a diffuse goiter that can be multinodular, that can be colloid is, can you see the lower border? Because I need to know something called as a retrosternal prolongation. Retrosternal prolongation is usually seen by a clinical history of a respiratory distress. Number 2, eliciting a test called as a Tim Burton sign and doing something called as a trail sign. Trail means you palpate the trachea down. If you could not palpate in the above the level of the supraclavicular area, that means the thyroid has encompassed into the retrosternal space. So please know that. So this is all about a diffuse goiter. Now coming on to, so how do we go for a clinical examination of the thyroid? Now whenever we go for a clinical examination of the thyroid, remember that whenever you go for a clinical examination of the thyroid, remember that, as I've said, inspection is something in which, as you know, you are required to know about the thyroid region and the retrosternal extension. Palpation, the conventional way of palpation is to stand behind the patient. The Lahaye's method is to stand on the side and push it with one hand. Trial is to now not use your hand, but to use your hand maybe to push the lobe on one side and to palpate the thumb. So the difference between a trial and a Lahaye is that in a trial, sorry. Now in a trial, remember, in a trial, you are required to palpate with your thumb. In a Lahaye, you are required to palpate with your full hand, curved backwards to fill the posteromedial lobe. So this is a very quick summary about how to go for a palpation. Now, the next point in concern about Lahaye and trial is, as I have said, notes are important. Number 4 are looking for signs of toxicity. Now, looking for signs of toxicity, guys, just give me a second. So let me show you a picture so that you will not forget this point, right? Now, before I do that, I really forgot a clinical caveat. Thyroid patients, like breast patients, are going to sit on a chair, not on the couch. Varicose vein and hernia stands, abdomen and peripheral vascular disease or arterial diseases lie down on a bed. Now, important words of concern in this are, this is the way that I palpate the conventional method. Okay. Now, important points of this are, I will not talk about berries, about the toxicity signs. Time is limited. Sorry. Now, when I talk about the toxicity signs, sorry. Hello. Am I audible, guys? My screen sharing just went out. Yes, sir. Sorry. Okay. My screen sharing went out. Sorry. Now I think I'm audible now. Is it visible now? Yes. Okay. Now toxicity is seen by 7 signs. First one, in the hand you see the pulse. Number 2, you see for a sweaty hand. Number 2, you see the pulse. Number 3, for again like your water hammer and all those things. Number 3, the patient should have a goiter. Number 4, if you have palpated a thrill, then auscultate at the upper pole. If you have palpated a thrill, auscultate at the upper pole for a bruit. Number 5 are eye signs. Number 6 are tremor. Number 7 are reflexes. Okay. Now, when you look for eye signs, remember to differentiate between a lid lag, exophthalmos, and a lid retraction. So these are all about the points of the chronology of these events. Okay. Now, so Dalrymple sign, Von Graves, Stelwa, Cocker, Mobius, and Navziger. So this is the way the thing goes by. Now, what is remember that the earliest of the signs is something called lid retraction or lid lag. This is due to a sympathetic event. The more it goes by, with more of deposition of tissues, in addition with the sympathetic, you get a proptosis. So this completes your answer. Navziger's is a method rather than a test in which you are looking in for proptosis. Now that question about is proptosis and exophthalmos the same? Not exactly. Exophthalmos, so this is from Browse's textbook of surgery or the clinical methods. If you can see both the upper and the lower eyelid, that is technically an exophthalmos. Okay. If it is proptosis, it has to come out of the eyeball. So this is all about things. So we have completed this little bit of thyroid very quickly. Now, management is something that you guys know of. Like majority of the cases with the diffuse disease will go in for a total thyroidectomy rather than a subtotal. Malignancy is always with a total thyroidectomy for a practical viva examination. Before I go to the rest of lateral lumps and then carotid, your questions, please. On thyroid. Hello? Hello? Am I audible, guys?
Yes.
Right. Your questions on thyroid. No questions? Wow, that's great then. Hello? Yeah.
The toxic audio also. First and second slide, please.
This slide?
Yes.
Okay.
So what is the fourth point of non-toxic?
Fourth point of non-toxic. Fourth point of non-toxic is the cancer. Sir.
Cancer. Okay.
Okay. Right. Have I made you understand this point now? So thyroid done. So let us now come to head neck cancers a little bit. Now, head neck cancers, remember, will always be present as a case in India because they are so common. Now, in a head neck cancer or an oral cancer, now in an oral cancer, now in a head neck cancer, please remember that in an oral cancer. Okay. So in a head neck cancer or an oral cancer, what you are required to know is that the presentation number one is that think about the primary. Now when you talk about the primary talk about the site. Okay. The site of the primary can be either on the tongue, which is very common in India, or on the buccal mucosa, the commonest in India. Now, when you talk about the buccal mucosa, that means the inner aspect of the, so that means you tell the patient to do and that means the cancer is on the inside of the cheek. Now, these are the two most common sites. Apart from them, what you are also required to see in this is the palate, both hard and soft. Particularly, number 2, you need to see the retromolar trigone, which means the areas. If you think of the mandible, the molar tooths, the third molar, the second molar, and the first molar will end at this point. Then you have the premolars, okay, and then you have the canines, and then you have the incisor teeth. Then behind the third molar, there is a triangular area which is called as a retromolar trigone, and this retromolar trigone is usually in the inside, you get the pterygoid group of the muscles. That means if an cancer, say for example, arising from the tongue or the buccal mucosa, has to make its way to infiltrate the floor of the mouth, which is this part, it is not going to produce a trismus. It can produce a trismus only and only when it can involve the retromolar trigone. It can involve the retromolar trigone, then it can produce a trismus. So you are asked this question, how can it produce a trismus? And so these will be the issues about how it can produce a trismus. So tongue, buccal mucosa, palate with a retromolar trigone is this point. So this is this part. So sight, tongue and the buccal mucosa. So this is the first point about the sight. The next thing that you are required to see in a clinical examination is talk about the presence of leukoplakia.
Sir, lip.
And erythroplakia. Sir, we are coming to lip again. Lip is the last one. Let us talk about the oral cavity first. So leukoplakia and erythroplakia, because the lip is a different biology. So talk about leukoplakia, erythroplakia. Now there is a bit of confusion in leukoplakia and erythroplakia. The reason about saying like this. Now, this is the area of whole of leukoplakia. Say for example, it should have been white. I marked it with this color, and out in this color, you had one area which became with an cancer. Now, you are confused around that. What will I describe exactly? What is my description exactly about this cancer? Okay, what will I exactly say about this cancer? So this is your fundamental question that you are always very confused. The answer for this is that some people feel that no, the cancer has started around, this is the surrounding. The answer is no. Any ulcer has a surrounding, and this is the surrounding, which is a leukoplakia or an erythroplakia. This is the margin of the ulcer. So whenever you get to see a clinical picture or a patient, understand what is leukoplakia, and in the center of a leuko or erythroplakia, you will find the ulcer of a cancer. Definitely it's sometimes. So the margin is usually ill-defined. Then you have the floor of the ulcer. Sometimes in between them, you have the edge of the ulcer, which is usually an everted edge suggestive of a squamous cell cancer. And what you did not see but you felt was something called as the, what is this thing is? This is the base of the ulcer, which remember is palpated. So you need to palpate the base of the ulcer. You need to palpate the base of the ulcer. So this, guys, completes your understanding about what is what about this point. Okay. So this is the first part. Now, talking about lip. Lip cancers are not very common in India, but are more common in the Western world, given that they smoke cigarettes, but in Indians smoke bidis. They can present either as a nodule. So then describe it that I can see a subcutaneous nodule of a size of approximately 1 centimeter, but majority of nodules, as you will see, will usually ulcerate. And with all ulcers, as I have always described, what are the things to comment? Surrounding, margin, which in this case in the lip, it will be a well-defined margin because you could see that. Then you have the floor, then you have the edge of the ulcer. The surrounding, margin, edge, and this point. So this is all that completes your description about the T part of this story. Remember that in a head neck cancer, the size of the lesion mandates and talks about the T stage of the disease. So you are required to measure it preferably with a vernier caliper. But it is not always practicable. So at least try to measure it with a paper scale about the T. Now, the next point is to palpate about nodes, which is again unilateral or ipsilateral or contralateral, and this Remember, who is important, and your examiner is going to ask you about an N1, N2, and an N3. N2 is again divided into an N2A, N2B, and an N2C. So you are required to know about this part very accurately and a part of a head neck cancer. Now, in a head neck cancer, the usual viva questions will be on etiology, which is a theory. Number one, you are asked about how does nicotine or tobacco produce the cancer. Remember, apart from a DNA methylation, it produces a lot of field changes in the mucosa. Number two, what is the role of a palm or a betel leaf and a betel nut quid? What is a betel nut? What is a quid in the causation of a cancer? The second group of the questions that will be asked is about after the etiopathy or after the etiology is discussed, is describe the ulcer. This is something that you have done. The next question will be, why did you call this to be a cancer? The answer for that one, sir, will be very simple. Sir, because number one, there is a history of addiction of nicotine and etc. Point number two is that the patient had a history of addiction. The point number two in the story was there was a history of a rapid growth. Number three, there is a history of occasional bleeding from the ulcer. Okay, so this completes. Along with that, I could feel an induration at the base. Number six, the nodes, if palpable, will always go in favor of a cancer. Now, what is the treatment that you have planned for this patient? What is the treatment that you planned for the patient? Sir, I would like to confirm my diagnosis. I will like to confirm my diagnosis by taking a punch biopsy from the edge of the cancer. Why the edge of the cancer? Can anyone tell me why the edge of the cancer? Why the edge of the cancer?
You know the site of proliferation, maximum proliferation.
Very good. It is the growing site of the cancer. So please don't say comparing things. It is the growing site of the cancer. Next one, after you have confirmed, I like to stage by doing a contrast CT of starting from the skull base, because I need to see the foramen in the skull, and then I need to go up till the superior mediastina, in which I will request my radiologist to comment specifically on the nodes and what level of node involvement are there. Okay, examiners will ask, how do you know that those nodes are involved? Remember that a normal node is oval, a cancer node is circular. A normal node maintains the kidney shape. This is done. A cancer node usually has a necrotic center, the peripheral enhancement. Matting is not a characteristic of only granulomatous diseases, can be seen in a cancer also. Size of the nodes more than a centimeter are usually considered to be significant in the neck, but people have now proposed that it can be more than 8 millimeter also. But for discussion, we'll keep it as 1. After the staging CT is done, then you discuss the patient always in an MDT or a multidisciplinary team meeting with medical oncology, radiation oncology, reconstructive surgery about what should be done. And then definitely you will be there in the MDT. After the MDT is done, remember the local surgery that you do is always a wide local excision with a centimeter margin. Then this is followed by a neck dissection. Now, when to do a neck dissection, or what type of neck dissections, and what are the types of neck dissections that are usually done? The answer for this is very simple enough. Okay, the answer for this is simple enough. Neck dissections, if the nodes are palpable, this kind of neck dissection is called as a comprehensive neck dissection. This is not an old terminology, this is a standard terminology and includes either a radical neck dissection or a modified radical neck dissection. Radical neck dissection removes, remember, levels, both of them are known to remove levels 1, 2, 3, 4, 5 and if 6 if required. But radical neck dissection also removes the internal jugular vein, spinal accessory and the sternocleidomastoid. Modified radical neck dissection 1 preserves the spinal accessory nerve. Modified radical neck dissection 2 preserves the spinal accessory plus internal jugular vein. Type 3, all of these three structures are preserved. Always remember that. Okay? But both of them are going to take the tail of the carotid and the submandibular gland. So this is all about the important point in the story. So comprehensive neck dissection. So either it can be radical or modified radical. Now you tell the patient that you are going to have a radical rather than MRND because MRND is a specific operation. Depends upon the operating site and the skill of the surgeon. If it is not palpable, people have been confusing with terminologies. People have called it as an elective neck dissection. People have called it as a functional neck dissection. People have called it as a selective neck dissection. Any of these terms. Remember that example being a supraomohyoid neck dissection is done with removal of levels 1, 2, 3 only, but is only done when the tumors are at T3, T4 or they are poorly differentiated. So this is the point that ends the discussion about head neck cancer. So I think that we have discussed two of the big cases today. So I think that we'll end with the carotid and the head neck. The next teacher, Dr. Sarkar, will come and then we'll talk about a carotid lump. Now, in carotid, again, the answer is very straightforward that why did you say this lump is a carotid swelling? Now, the first question is again, why did you say this is a carotid swelling? Is dependent upon why is this a carotid swelling is classically dependent upon, so the location is in something called as the carotid region of the face, which is, hello, am I audible guys?
Yes, sir.
Yes, sir.
Now, which is something that is limited above by the zygomatic ridge, upper 1/3 of the neck. In the front, you make a line from the zygoma till the mandible. And behind, you make a line that joins the mastoid with the neck crease. So this region, upper one, is a zygomatic ridge. So this region of the face, not the neck mind you, is the carotid region of the face. So anything in this area, please think over it as a carotid. Number 2, if the ear lobule is pushed upwards and outwards. Number 3, so carotid region of the face is done. So number 3, upwards and outwards is this. Number 3 in this story is now the retromandibular, not the retroauricular, the retromandibular groove is obliterated. So the retromandibular groove is obliterated are the 3 points that tell you that this swelling is a carotid swelling. The next question is, if you have said this is a carotid swelling, why did you say this is a benign or a malignant carotid swelling? The points that goes in favor of a benign carotid swelling are slow growth, absence of pain-free. Now, pain is not a very constant feature in cancer also. Facial nerve is not compressed. Again, is not compressed in all cancers. Consistency is firm is a misnomer because cancers can also be of firm consistency. So, apart from the slow growth, then nodes are not involved or palpable is another important point. So nodes are not involved. Okay. So please understand that slow growth pain-free facial nerve is not involved and form are important points to talk about. So why is this a benign carotid swelling? Is these points. Now the most common benign carotid swelling is a pleomorphic salivary adenoma, and examiners will like to ask you what are the other things that you have seen. Sir, I have seen the enlargement of the deep lobe by taking a history of difficulty in chewing and by inspection. Please do not stop yourself by talking about palpation, because doing something called as a bidigital palpation is very difficult for you and the patient also. So like an invagination test in hernia, I will stop at this point. But preferably I can do an imaging like a CT or an MR to see about the deep lobe if I suspect a deep lobe involvement. So this was all about there in a carotid. Things are very straight down there in a carotid. Some people have added a sign called as a curtain sign, which is not a very well sign to understand and explain. In this one is why is it a carotid swelling. Now, what is your plan in treatment of a carotid swelling? The first one is that, sir, I want to confirm my diagnosis by doing an ultrasound of the head neck region, which will tell me the organ of origin, which is a carotid gland. Number two, I will like to do an ultrasound guided FNAC. I will like to do an ultrasound guided FNAC from the swelling to confirm my diagnosis. Usually your accuracy rates are more than 95%. Examiners will ask you if it is no, then what will you do? If it is negative, you can repeat an FNA, which is going to increase your yield till 98%. Then the examiner will ask you whether will you do a core needle biopsy. The answer for this is in a DNB and an MS examination, maybe I will not do that. But if you read the literature on the meta-analysis that has been done, yes, it is a practice thing now. We do not do an incisional biopsy because that can injure a nerve. The facial nerves can be injured. But what is important is core needle biopsies are still done if you have a doubt in carotid, but better not mention in an exam. After you have confirmed, counsel the patient for a superficial carotidectomy, which means that there are two lobes that are divided by three structures: the facial nerve, the retromandibular vein, and the maxillary artery. Now, if you have removed the superficial part only, that is called a superficial carotidectomy. If you have removed the superficial plus the deep lobe and you have preserved the facial nerve, that is called as a conservative carotidectomy or a total facial nerve preserving carotid surgery. Finally, in a case of malignancy, if it is proved, remember, for a malignancy, if it is proved, now, majority of staging is done by a CT of the head neck region. CT from the skull base to the clavicle. You see for nodes, as I have always told you. But if it is a adenoid cystic, which remember is a propensity to spread to the brain, it is always important to do an MRI of the brain plus a local MRI, particularly with a facial nerve attention. That means the radiologist needs to be told that it is very difficult for them to see and comment on the facial nerve. Remember that the operation for a radical carotidectomy is going to take not only the two lobes of the carotid, but also to take the nerve, the facial nerve, the artery and the vein. Now what is important is that whenever you understand the facial nerve trunk is an important viva question, and we'll end at this point. If this is a stylomastoid foramen, then understand that at an operation of an parotidectomy with an incision of parotidectomy being described like this, that it is 8 centimeter in front of the tragus of the ear, goes to the mastoid and again curves down in the upper 1/3 of the neck. So it is called as a lazy S incision, also called as a modified Blair's incision. 1 centimeter in front of the tragus, gentle curve to the mastoid, and then it curves to the upper 1/3 of the neck. Now, how to find the facial nerve? Remember that after this incision, retract the sternocleidomastoid. You will find the posterior belly of the digastric. It needs a little bit of digging to find it. So you need to search for this posterior belly of digastric. When you retract the posterior belly of digastric, remember, then lift the ear cartilage upwards. When you lift the ear cartilage upwards, then 1 centimeter below a pointer called as a tragal pointer, and 1 centimeter in the depth, you will find the trunk of the facial nerve. Taking a nerve monitoring tool, I do not know will be helpful or not, but what I usually will always do is that 1 centimeter to the deep of the facial nerve, I will find a bony spicule called as the styloid process. So the facial nerve is found by finding the tragal pointer or the cartilaginous pointer, and then finding the nerve 1 centimeter below and to the depth. So this is how I find the facial nerve. Remember that in a adenoid cystic, you are required to excise the full length of the facial nerve. Reconstructions are done by cable grafting, particularly the sural nerve. Okay, so this is all about the carotid that you are required to know. So guys, we have completed this part. So tomorrow when I have my head neck, I have my instrument classes. I think that I will be discussing with you the neck lumps, like particularly the neck nodes for half an hour, and that will end the class. Because if I continue more, we will be late for the next class. We have completed thyroid, oral and carotid today. Any more questions, please? Just a quick two questions only.
Sir, in carotid, sir, can you show this notes for radical parotid?
Radical parotidectomy, please remember, is going to excise superficial, deep, and the 3 structures, and along with that, you are going to do an supraomohyoid neck dissection, if not a comprehensive, and you are also required to excise the masseter if it is involved, sometimes even the mandible if it is involved by that. But up till this is something that every resident should be able to tell. Oh, the skin over which the biopsy was done should be excised also. Right? Sure. Any more questions, please? No more? Hello? No more questions? Hello?
Yes, sir.
Okay, no more? I think that I will stop.
Yes, sir.
Achha. Has Professor right? Sorry. Professor Sharkar has arrived, so I think that I will be ending now. Nikuda, good evening. Hello?
Good evening.
Hello? Hi, good evening. We can start now. Yeah. I am 10 minutes late. Very sorry.
Oh, no, absolutely fine.
Okay, thank you.
So, can I have the screen sharing option?
Yeah.
Thank you, sir.
Thank you. Shilajit, please
Thank
give Dr. Sharkar the screen sharing option.
Hello?
Yeah.
Hello?
Hello?
Sir, I have available screen sharing option. Sir.
Am I visible? No, not till now. I will leave meeting and come back. What is subtotal thyroidectomy? No, Dr. Shokar will join back. Achha, someone has asked you in the chat, so by the time I am here, what is subtotal thyroidectomy? Hello? Someone of you have asked what is subtotal thyroidectomy. Again, this question goes on for eternity maybe. Subtotal thyroidectomy. Can anyone tell me what is subtotal thyroidectomy? Hello.
Yes, sir. Now the screen sharing option is open.
Okay. So, as you know, we are going to go very fast because it's a boot camp, and therefore I was looking into the actual meaning of this term boot camp, and I understood it is an army drill. And it seems that all of you are more or less prepared for the exam. It's just a sort of brushing up.